onto the Facebook.
Yeah, and that's true. It's also streaming live through Facebook and Twitter and Instagram.
Yes, I also see the +2 and my
Right.
eldest like to leave it as written.
Okay.
Keep busy.
Yes.
No need to.
It's like when I
You'll
click
give me
on
the
the
signal,
guide.
Erica?
Yeah, sorry, I got it. I just forgot that I was at the computer.
You are.
All right, do you want to? Yeah. And then we're just giving Ethan a moment to get all of the socials
Sure.
up and going.
Hi, everybody. By the way.
Hi.
No, we are good to go, Ethan says, so.
All right.
Cool.
Well, hi, everybody who's here in the room at 464 Metcalf. Our beautiful landlord, the Centertown Citizens Ottawa Corporation, owns this space. It's a cooperative space. One of the biggest nonprofit housing provider in the city is CCOC. Also, our landlord down the street, we're at 109 Catherine. Hello to folks tuning in. Well, I guess I should look at this owl device that.
If you look at the owl, they will actually
Owl.
get your face going
Okay.
right into it, yes.
All right, well, it's my introduction to the owl concept. So hi, everybody tuning in online. I'm going to be reading out a roster of folks who have agreed to participate in this wonderful event, which is a primary care roundtable. So there's a number of neighbors who have reached out to us very concerned about the state of primary care in our community. This is something we're hearing about a lot at the legislature. So our impulse, as it is pretty much with everything, is to open up the door and let neighbors tell us what they see as the critical issues for primary care in Ottawa Centre. I'm very proud also that we have some folks who are going to be joining us online and in person who bring a lot of expertise to this conversation. Also happy to say Ontario Health East, which is the governing body for healthcare administration, Karen O'Brien, who's the Director of Communications, is joining us. I've asked them to join us because what I hope we can develop in our conversation this afternoon is a report that we can provide to Ontario Health East and to the government of Ontario to say, these are Ottawa Centre's key insights on what we need to do on primary care in our community. So I'm going to resist the urge to editorialize off the top and drop all of the facts and information that I know is going to come out in our conversation. Suffice it to say, this is a really critical issue. And I've been hearing about it from a number of different people. I'm already, though, far enough along that I should have stopped initially to acknowledge the land that we're on. We're not just at 464 Metcalf in a CCOC building. We're on unceded Algonquin and Anishinaabe territory. And as we do all the time when we meet in our community, I want to acknowledge that I'm guest in this space and I value the friendship of Algonquin and Anishinaabe neighbors. And one of the things I've often heard from Algonquin and Anishinaabe neighbors is the notion of gratitude and the notion of friendship and working on those things all the time, not as just words that we say or territorial land acknowledgements we do as a tick box exercise, but to say, you know, if we're truly committed to this project called reconciliation, that actually means engaging in those relationships in a serious way with gratitude, with intent. And the intent is, I hope we're all committed to do this afternoon, is to shed some light on the primary care needs we have in our neighborhood, which certainly impacts everybody. Very happy, and I'll get into this now, that we have some people here with us who can lend a lot of expertise. So I just want to take some time to acknowledge them before I actually call on them person by person. Generally, what we're aiming to do in our roundtable this afternoon is give each speaker a good 5 minutes to present to us their insights about Ottawa Centre's needs on primary care. But very glad that Michelle Hercuis from Centertown Community Health Centre is with us. Omar Samhan, is Omar with us on the Zoom? Okay, maybe joining us soon. That's okay. Omar, maybe he's from Carleton Community Health Center. Shireen Noble from Our Care Priority just released a comprehensive report on primary care is with us. Joanna Binch from the Registered Nurses Association of Ontario is with us online here in the room. Anna Kulitz from SWOOS. Seniors Watch for Old Ottawa South. I was struggling on the first two letters, Anna. Ed Cashman from the Ottawa Health Coalition with us too. And why don't we just, for everybody's benefit tuning in online, we'll just do a quick tour de table, as our French friends say, if people want to just provide a brief introduction of who you are. Let's start right here.
Oh, go with me, okay. My name is Dominique Gagnon. I live in Canada, but I'm
Okay.
interested about healthcare. I'm working actually on a new health radio program about health with Unique FM. So that's why I gather a lot of data right now. I have a lot of findings and I'm interested about what you have to say today.
Et je peux dire aussi, Dominique, parce que votre accent, un accent
Oui.
franco-ontarien, c'est
Oui,
super.
ça je ne peux pas.
S'il y a du monde sur le Zoom ou ici qui peut parler en français, on est capable pour comprendre votre commentaire en français. Mais merci pour être ici.
Bienvenue.
David?
My name is David Whiteman. I am a support services worker at the Civic Hospital and a community activist.
My name is Brenda. I'm an interested community member.
My name is Ty and I work for Joel, but also very interested in this. Erica, and I also work in Joel's office.
My name is Lily. I'm an interested community member as well.
I'm Carolina. I'm a community activist.
Okay, and I think we've introduced, but
My name's Rosie. I live in Old Ottawa South. My children haven't had a pediatrician for ever. It's my husband works for global affairs. It's almost tempting to go on another posting just so we can have healthcare.
oh my goodness.
It's ridiculous. So I'm here as an interested party. I'm also a non-practicing registered nurse. Getting my registration back is another, if they ever answered me, would be another story, but anyway.
Work on that after the meeting. Now, anybody I'm missing online, Erica or Ty, that I haven't acknowledged? Okay, great. Well, why don't we begin? Gave Michelle a heads up that I'd be asking for your
Yeah.
help to start us off, and Anna will be going to you afterwards, kind of coming from a community service perspective to a citizen perspective, engaged citizen perspective. So, Michelle.
Absolutely. Thank you so much, everyone. So I've worked in community-based primary care for close to 30 years. And I have to say that there was a time when I think in the 90s, when we used to say there was a million Ontarians with a lack of access to primary care provider. And I think we're now at probably 1.5 or 2 million individuals who don't have a primary care provider. And, you know, in my conversations with many concerned citizens, many concerned politicians, many concerned bureaucrats around some of the reasons why that is, there are a number of issues. And first and foremost, one has been the changes in the way that primary care providers practice, and we haven't changed along with it. So we used to have family physicians, as an example, who would have a practice with 10,000 clients as a solo physician. And we knew the difficulties of getting in to see them, but you technically had a primary care provider. Most primary care providers, whether it's a physician or a nurse practitioner right now, will not carry that large of a caseload. And we haven't adjusted either our enrollment numbers in our medical programs to adjust to that, nor have we actually changed our funding models. We are still heavily dependent within the OMA agreement, quite honestly, largely on a fee-for-service OHIP billing model.
Right.
A physician can set up anywhere, but if they want to, so they can set up in a walk-in clinic, and we see that in terms of when we talk about some of the privatization models, the apple trees and the all of those kind of walk-in models is, as a family physician, I can go set that up. I don't have to do anything. If I want to practice as a physician or a nurse practitioner in a primary care model, I have to apply then to be either part of a community health center. Community health centers and Aboriginal health access centers only comprise about 5% of access to primary care in this province. So we're a very, 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 very small piece of the puzzle in terms of access to primary care. And our model is actually based on, we are considered an alternative payment model because all of our providers, our physicians and our nurse practitioners, are 100% on salary. So we do not invoice or bill OHIP, and we have established targets that we need to hit in terms of a number of preventative care pieces, but we don't get any additional incentive, and nothing else is adjusted for us in terms of how many patients or clients we take on. We do have in our accountability agreements with our funder, Ontario Health East, and through to the Ministry of Health, agreements that based on what the model is for physicians and nurse practitioners and other models of care, based on what their baseline is, we have an adjusted number of clients that we see based on our complexity of care. And so I think when we're looking at the access to primary care, one of the things that I think it's important that we take a look at is in those 2 million adult individuals who don't have access to a primary care, we actually know that there's a disproportionate amount of individuals who have significant barriers to accessing care. So we did hear about someone who is sort of at the end whose children don't have access to a pediatrician. An increasing number of seniors don't have access to primary care. When their physician retires, it's harder to get onto somebody's roster because they're considered more complex. But if you have a language barrier, or if you have complex mental health issues, or you have complex physical health issues, often what will happen is in the other models of care, other than CHCs as an example, and there certainly are some exceptions to this, you will often see that they don't want to take the more complex individual because the fee structure is only adjusted for age and sex and not complexity of care. And so it becomes a lost proposition for them. It's harder to make money. And we have a couple of examples, I'll just say in our community. The Restore Clinic is a really good example of a group of family physicians who are really working hard to provide services to individuals who are immigrants, newcomers from racialized communities. They have poorer health outcomes because of systemic barriers in our healthcare system, but they have struggled to get funding for anything other than a fee-for-service model. And the fee-for-service model does not really well respond to those client population needs who are often coming with more complex health issues that have been ignored for longer because they actually haven't been able to get access to care, not because the individuals weren't trying to get access to care. But for example, community health centers, there are 73 of us across the province. As I said, we make up 5% of the care that's provided in primary care across the province. But we have not seen any expansion of the community health center model of care since 2005. In 2004 and 2005, we went from 56 community health centers to 75. There's been some amalgamations, but there hasn't been any significant new investment in funding. And before the 2004-2005, the last major investment was 12 years before that. So we have not been a model that has been invested in, despite the fact that as a model of care, we see clients across the province that are almost as twice as complex as individuals that are seen in a general primary care practice, so like your typical family health team. And our clients have a lower utilization of emergency room departments by somewhere in the neighborhood of, looking at the data, of 20 to 30% lower utilization of emergency room departments that would have been forecast by their complexity of care. So based on sort of their age, their gender, their healthcare conditions, we use emergency room departments 20 to 30% less, because of the kind of wraparound services that we offer in a community health center. I know we're all talking about primary care, which for most people, they think about it from the example of access to a physician or their nurse practitioner increasingly more and more. But the plug I want to give for interdisciplinary teams and those wraparound supports is that we know that once you actually do have a family physician, your health outcomes are more determined by your social supports, the sense of connectedness to your community and neighborhoods, the ability that you have and the supports that you have to navigate the broader healthcare system than that actual physician or nurse practitioner. So they're essential. They're an essential gateway into our system, but our health outcomes are determined by that sense of connectedness and cohesiveness. So even as we are looking at the challenges of access to a family physician or nurse practitioner, I want us to really hold on to thinking about how we continue to expand that interdisciplinary team to support people, particularly as we are looking at an aging population that needs more of those supports to remain in the community. As we're seeing increasing numbers of immigration and newcomers that need more supports around system navigation and access from language and culturally competent care, that we're having those conversations about what are the other wraparound supports, not just looking at increasing the number of physicians and nurse practitioners.
Okay.
So that's where I'll kick us off on.
Thank you, Michelle. Thank you. Quick question on the technical side for Eric or Ethan. Do you know if is this being fully recorded so we can make sure we have a transcript too we can utilize?
Yeah. Yes, it is.
Thank you, Ethan, wherever you are. Okay. Thank you very much. That was like the voice from above. Thank you. Thank you very much. I'm focusing on the conversation, not
Yes,
taking notes.
absolutely.
Yeah.
Well, thank you, Michelle, for starting this off. Over to you. I mean, we know you in Old Ottawa South as a major advocate on primary care, and I know you've worked with neighbors. So please let us know what you think Ottawa Center's needs are.
Thank you, Joel, and thank you for creating this opportunity to address our concerns, all our concerns about the lack of primary care in the region. My name is Anna Cowlitz, and I speak on behalf of Senior Watch Old Ottawa South. It is usually known as SWOOS. Now, SWOOS is a committee of the Ottawa South Community Association, but we collaborate with surrounding communities. It's not just Old Ottawa South. We have even been asked by other community associations if we would collaborate with them. We have been around for 5 years already, and we have learned a lot. We have learned what works for seniors who want to age in place. And we came the last few, I can say 2, we have moved so much the last year, it's very intense. So we really are interested, have come to the conclusion that it has to be geriatric appropriate care. Now, the problem is, nobody knows how many of our local seniors don't have access to primary care. It is, I can tell you, we have SWOOS has quite a large network. I think of it's now it's probably 30 people, let's say. And we have a statistician, we have health sciences, 2 health sciences librarians who have tried to find statistics. They were unable to. You know, I'm very much precise. You know, we don't want to just grab numbers, but the number I've seen floating around is 6,500. But it seems also, according to Vera Etches, there are about 100 till 150,000 local people that have no primary care.
Right.
So our population must be at least 12% seniors. So then, I'm not that bad in math, but I would say it's already, you know, it must be more than 12,000 seniors without access to primary care. So I don't know why they keep talking about 6,000. But now another clincher. Quite a few of us are, in 5 years, the baby boomers, we are reaching the frail age. I won't tell you my age, but I'm facing in 5 years, I'm maybe even 80, I won't tell you.
You only look 16.
Yeah, I was gonna say, we wouldn't believe
I
you.
just keep biking, Now, there's one problem, and Michelle would know this very well. Seniors tend to deny problems. If you ask them, I've worked in Emerge, how are you? I'm fine. They might be laying on the floor, but they are fine because that's how they cope. So they say they are fine, but how well is their diabetes controlled? How well is their blood pressure controlled? What other problems do they have that are not diagnosed? Another problem is that older adults are overly medicated. I've worked in rehab, geriatric rehab. Well, the pharmacist used to say, well, we cut the medication in half. There are interactions between medications. Even simple aspirins are dangerous. Then if you have no primary care worker, whether it is a physician or a nurse practitioner, who does the assessment? Who does the blood work? And all the other tests, if you don't have primary care? Walk-in clinics or emergency departments, they are not the best places for this. And so that's why SWOOT works on innovative solutions to support aging in what is the right place for each person. We have developed 4 teams that work on innovations, and I won't go into that because we do so much that I get tired even if I mention it. But in passing, we have a very interesting innovation on providing access to resources, information on that. Housing solutions is also a growing group, a growing team. We worked with the universities and the National Research Council on technical supportive solutions. But today I want to concentrate on the SHE, easy to remember, huh? SHE stands for our concept of Senior Health Innovation Hub. You can call it a hub, you can call it a SHE. It's a demonstration hub pilot that will operate in collaboration with established health and community service organizations. I've sent you the short form of the SHE proposal that I would like to be attached to your report.
Absolutely.
But I just want to mention that we propose that primary care will be provided by nurse practitioners, nurses, RPNs, and that they could be virtually linked to a health team. It's an idea, but we have to work on the details. But there is substantial evidence that nurse practitioners can provide primary care to seniors at equal or greater quality and at equal or lower cost than physicians can. This is not against physicians, it's just what works better. Now, as recommended by Ontario Health East, I won't mention names, but we are currently working on a comprehensive funding proposal with Michel Orteviz. So in closing, you gave me only 5 minutes. Huh? In closing, I like to summarize and recommend that the Ontario Health funds the Senior Health Innovation Hub. Remember, the hub, as it is very well researched. It is developed by the community, by the boots on the ground. And we have done a survey that I don't even want to quote because I'm very much into fact, our whole group is. And we really think that the hub, the SHE, is a sound answer to a wicked social problem. The SHE would improve access to geriatric appropriate primary care, supportive services that would improve the conditions for seniors aging in place, prevent ER visits, hospitalization, long-term care placement. And we really like the community to work with us. I thank you for your attention.
Thank you, Anna. Thank you very much. All right. Well, I want to pass the mic if it's possible. This will be our first panelist we'll be bringing in from our digital space. But Shireen, can you hear me?
Yes, I can.
Oh, wonderful. Well, I would like it if you could pick up from where Michelle and Anna left off, Shireen, and just by way of a brief introduction, you can elaborate more on your expertise and what you share with us. You were part of the Our Care Priority Panel in Ontario that just released in early April, a pretty comprehensive 71-page report on primary care. So thank you, first of all, Shireen, for joining us. And over to you. Help us understand what you think we need to grasp when it comes to innovation in primary care in Ottawa Centre and more generally.
Thank you so much. I'd also be happy to turn on my camera if that function
Can we
can
make
be
that-
enabled.
Can we make that happen, Ethan? Sorry. Zoom is a wild and funny place. I'm sure it'll happen soon, Sheree. Wow, this owl thing really is cool. The only thing for comic relief is we had these for our caucus meetings, just for the last 2 caucus meetings. And for some reason, I always seem to sit in the corner of the table where it's catching a close-up of me eating a sandwich.
Yes, that is, it isn't as forgiving as, you know, the large, like a webcam that just gives the panoramic view of the room, because it does just,
Erica's looking at some, yeah. How affordable are these? Ethan, can you hear me?
I think they're a
Yeah.
little bit pricey.
Oh,
They're about
can you
1,500.
enable the screen capacity for Shereen?
We do a lot of hybrid, and it makes a huge amount of difference.
If not, we'll just
Yeah,
go with audio.
I cannot, no, sorry.
Okay, that's okay. Shereen, do you mind if we just go with audio? And I apologize.
Yeah, no problem.
Okay.
So thank you so much for having me here. As part of my background, I was or not because of my background, but I was chosen to be part of a panel called Our Care, which was a citizens panel that gave some recommendations about what the future of primary healthcare should look like in Ontario. Now, the fun thing about this is they didn't realize I work in public health and have lots of ideas about it. So we did talk a lot about funding and different ways we could approach some of the challenges that are being, that are really facing everyone. I know personally in Ottawa, I'm out in Bell's Corners, but you know, everywhere there are the waiting lists. There are, you know, my father is going through cancer care, and you know, it's wild, wild west out there, basically. So there were 5 basic problems we wanted to solve. One was the fragmentation of our healthcare system. The second was the inequities within the disparities of access and quality of care. Third was the obsolescent data systems that we're using that do not speak to one another. So if you get, you know, your blood test done with one doctor, the other may not be able to see it and send you for another one. So there's a lot of duplication of care that way. We have basically a health human resources crisis with not being able to keep enough healthcare providers. And it's not surprising after the way they've been treated during the pandemic. And primary care is not prioritized in health system planning. So if we were to take these issues, we would say, look at these issues and say, there's no money to put more money into healthcare, into primary healthcare. But by investing in primary healthcare, we know that it would flip. And the amount of money that we have to spend on secondary care, hospital care, palliative care, places like that would be much less. So we came up with a few values to guide our discussions. And what we decided was the reform of our healthcare system has to include, first of all, we were unanimous across the province that it has to be public and universal. So there is a lot of support to continue with our public healthcare system. Personally, I went to school in Florida, and you know, I am so proud of our healthcare system compared to what they have in the US. We wanted to make sure there was continuity and accountability for healthcare providers, that it was evidence-based and accessible, and want to make sure that our healthcare becomes and remains holistic, intersectional, and culturally responsive. So lots of big ideas there. And we came up with 6 suggestions for how we could go about this. The first one's my favorite because my background is as a public health educator. One thing that's important is that we let patients know what their rights are. Right now, we don't actually know if we can ask someone for a second opinion. We don't know, is it appropriate to go into my doctor for a yearly physical since they've taken that away, or to check in about something little. And we also, through a public education, we want to talk to people, train the trainer model of how to access and navigate the healthcare system, which is something that is desperately needed. Especially among mental health cases, people with mental health concerns, there is no continuity of care and no clear pathways. We want the new system to be interoperable. So we want to make sure that if you go to your doctor's office one day and then you go to the Queensway Carleton Hospital the next, that the doctors there can find out what you were talking to your doctor about. We want to make sure that there is discussion between the different electronic medical record systems. We also want to make sure that patients have access to their own medical records, because that's not always easy. And that may involve something like having pharmacists who can help, older patients access their health records and such when they are not necessarily used to using the digital tools. We also want to ensure that we have a body to determine which research is acceptable and the ethical use of our data. So right now we do have a system where Ontario health data can be accessed, but it is kept very, very tight through ICE. And there are very limited people who can access that data. But we want to make sure that if used ethically, we can figure out what's going on in Ontario's healthcare system. The third thing that came up a lot was expanding coverage. And the most important part of expanding coverage was making it comprehensive. Eye care isn't included in your healthcare. Your pharmaceuticals aren't covered in your healthcare. You don't have mostly you don't have access to dental care. These are all things that I personally struggle with, because despite making a decent salary, I am paying over a third of my take-home salary to healthcare costs. We also want to increase linkages within the healthcare system and providers and social services. It's great that patients can get help where needed if the provider knows about the services, but that's not always the case. We don't have a great way to talk to one another. Then we were more interested in looking at the CHC model, as Michelle was discussing, because we know that that solo providers are facing an enormous administrative burden, as well as burnout. So we need to ensure that there are healthcare providers who can help one another. And by having people rostered with a team, you may not see the same doctor every time, but you can still get to see a doctor when you need one. We also talked about a centralized booking system for referrals, because right now, family physicians have to make referrals themselves often. And they are not, they could be required to make 5 phone calls until they find a specialist who's taking on a new patient. And that's just eating up their time. We want to ensure that the system is accountable. So we need to know, going back to that idea of the patient bill of rights, we need an independent body to keep everyone accountable. And we see that a lot in hospitals with the signs up about, you have to treat your healthcare provider with respect. And, it's terrible that we've come to the point where we have to put up those signs, but we also want to ensure that patients are being treated with respect and know what their rights are when they're not being treated well, and close the loopholes that allow for privatized healthcare. And finally, we wanted to talk about medical education and how it's being handled at the provincial level. The main thing is, we have lots of healthcare providers in Ontario. In fact, we have more healthcare family physicians in Ontario than we do per person than they do in other countries that have much better access to their healthcare providers. But that's because people who are graduating medical school and becoming general practitioners, a third of them are working within hospital settings or within other more privatized settings, private clinics. So we don't have, even though we know how many GPs are graduating, we don't actually have great ideas of how many of them are seeing patients. We need to accelerate newcomer healthcare providers. We need to figure out why people aren't going into general medicine. And we need to increase the number of participant spots in medical school to ensure that and some of those may be tied to going into family practice. All of these things were heavily discussed, and these were our recommendations from the R-Care panel.
Shireen, thank you. Thank you so much.
I'm just going to note that Ethan worked out the video problem, and so now panelists can turn their videos on.
Okay. Well, Shireen, turn your video on for just a moment so we can turn on. There you are.
Hey.
Thank you so much, Shireen. All right. So next we're going to pass the mic to Joanna Bench from the Registered Nurses Association of Ontario. Joanna, thank you for taking time to be with us this afternoon. Time away from patients and colleagues. It really means a lot to us that you've joined us. And we first met when you presented to the Finance Committee of the legislature when it came to Ottawa. I really enjoyed your insights then, and looking for, oh, there you are. Hi, Joanna. Looking forward to your insights this afternoon about primary care needs, Ottawa Centre.
Yeah.
Thank you. Oh, everything okay? And thank you for joining us. Over to you.
Well, I just want to say that I am speaking from RNAO, but it was my colleague Laura who had spoken with the Finance Committee. And so I think we had met because I'm a nurse practitioner and we're advocating for a nurse practitioner-led clinic proposal. So I think we'd met about that. So I just wanted to say thank you to all the presenters. I really appreciate your insights. And I think that it's becoming very clear that what we need here in Ottawa is attention, probably a lot of money, but also a team-based approach to care, because you know, as people are getting older, as the healthcare issues are becoming more complex. I've worked at a community health center for years and years, and so I can appreciate team-based care. I'm also part of the OHT here for Ottawa, and as part of our OHT with Michelle, we have submitted the collaborative proposal for addressing the primary care issue. And so as part of that proposal, there are different aspects, and really all of us need to be moved forward. So it needs to be more CHCs and expansion. It needs the restored medical clinics, great idea. Expansion of our academic family health teams, absolutely. And so what we have done with the support of RNAO is put in a proposal for a nurse practitioner-led clinic. So I'm sure I'm preaching to the converted about nurse practitioners, but nurse practitioners are registered nurses with extra training. So we can do things like prescribe, order x-rays and ultrasounds, diagnose, and manage chronic and acute conditions. And so as many of you know, in several countries, including the United States, it's more common to have a nurse practitioner as primary care, and then physicians are more of a specialty. And because most people, their health issues can be in primary care, can often be addressed by nurse practitioners without anything further in terms of needing the acuity of a family doctor. So that being said, I want to be very clear. I'm pro-physician, I'm pro-healthcare provider, I'm pro-physician assistants to pharmacists. Like, we all have to be in this. We all have to be in teams. And it decreases the burnout. And I heard you say, Michelle, about how, you know, back in the day, it was 10,000 patients for one person. And I think those were the days that after a surgery, that people were not being discharged the same day with drains and tubes and, you know, all of the things that that kind of bring a level of acuity into the community. And the other thing is people are living longer. So we are seeing that as people do that, they have chronic conditions that we are being managed in primary care, and they're becoming really complicated. So I don't think that we can do this alone. And so one of the things that we're speaking about today is just that the nurse practitioner proposal is the difference with it is that it is a nurse practitioner model that has what we were proposing. Actually, we were looking to connect with the swoosh people. I'm saying it wrong, I think. Swoosh, swish, swoosh.
Swoosh.
Swoosh, swoosh.
Swoosh and the she proposal, which is the, yeah.
Because we were looking for where we could best fit for a nurse practitioner-led clinic. And so what we've kind of landed on is a mental health and addiction nurse practitioner-led clinic that's affiliated in a partnership with CMHA. And so it would have 12 NPs and have be offering care to anyone living with a mental health illness or an addiction and their families. And the reason why we're doing that is that, and then I should say, to finish the roster, it would be with, nurses and the pharmacists and a physician and a psychiatrist and a number of allied health, including addiction counselors. And so we're asking for $7 million and 10,000 patients that we would see for that amount, which is nearly half of the cost of a physician. Not that we should be talking only about money, but I think that in today's healthcare system, when we're hearing the federal transfer dollars of being only 62 million for the whole province for 2 years, then we have to really think economically about what would be successful if we are putting a proposal forward. And I really hope they fund all of us, but I think that we have to start somewhere. And this kind of project, as I say, the Registered Nurses Association of Ontario has been very active in saying that we need to address primary care issues in a number of ways, and one of them is NP-led clinics, so they've been very supportive. The other one is nurse RN prescribing, I should say that as well, is something that's being put forward by RNAO, but also just the fact that we talk about what is a nurse practitioner, what is a nurse, how can they be contributing to the primary care crisis, rather than the message. I know that I think, Joel, that we had actually said is that we met with the mayor's office to say, could we have a nurse practitioner on this table of the mayor who's looking to increase or address the primary care issue? And he said, all the voters are asking for a family doctor. So there's no need for a nurse practitioner on the table because we only want family doctors. And I appreciate so much my colleagues who also supported and came back and said, no, what we need are teams. We need to be thinking differently. We need to be talking about your primary care provider. And maybe that day you see a pharmacist or you see the nurse or the counselor, but that we have to be working together. And so I think that when we're moving forward for what we want to capture in a report, it is certainly to say that all of these models of care need to be considered in order to move forward. But because primary care has been neglected for so long, because we know with our aging population, I think I saw a statistic of 1 in 6 people are going to be over the age of 60 by 2030. So I think that, we have to be thinking about how we can proactively rather than reactively address this, and to also recognize a government who is very interested in short-term payments like urgent care clinics and walk-in clinics, and that what we need and we know that provides the best care are long-term relationships with primary care and facilitated access that isn't only 9 to 3 every other Monday from 6 to 9 on the odd Thursday, and to feel that you can't ever ask for more than one issue at a time, or you might get kicked out, and then what would you do? And so I feel like we need to look at our retention of the people that are there. One of the things for nurse practitioners is because nurse practitioners go back to school after they've been practicing as registered nurses, that they're more likely to stay in the city in which they have gone to school. So at the University of Ottawa, we have about 78% of our graduates that remain in Ottawa. And because nurse practitioners are funded on a salary, they can't just set up shop with OHIP billing. So we have a need to be funded directly from the ministry. And with that funding comes the situation which we have now in Ottawa, which is that we have more nurse practitioners than we do jobs for nurse practitioners. And so when I hear about the situation of not enough primary care, I think how unfortunate that we have people who'd like to work in these primary care models if we just had a bit of funding. So as we're trying to attract people, I just want to remind any proposal going forward is that we have some solutions that could be started tomorrow if we could just figure out how to fund that. So any support for that will be appreciated. Anyway, so thanks for letting me chat about that, and I'm happy to take questions.
Thanks, Joanna. We'll get to the Q&A round
Absolutely.
very shortly, but thank you for being with us. We're going to end off sort of the invited folks who are offering some remarks.
Just Omar has joined as well. So Ed, I know there's Ed, but Omar has actually managed to join.
Hi, Omar. Nice to see you.
Hi, how are you? I'm so sorry, I was late trying to join.
That is okay, my friend. That's okay. I'm glad you're with us. If you don't mind being put on the spot, Omar, I'm wondering if you could add any thoughts from Carlington Community Health Center, wonderful organization that you're part of in the west end of the riding. When you think about the needs that the catchment area for your community center serves in primary care, what are those needs you'd like us to be aware of for our report?
Yes. Actually, I was hearing everybody saying all the challenges we have and opportunities we have at this point. But actually, my experience working with so many doctors and nurse practitioners in different provinces. Actually, what I'm seeing more and more, and I'm gonna do echo to other comments. Actually, is the burden for clinicians at this point. It's really hard for them, and I'm seeing that every day working with doctors and nurse practitioners, how much time they spend actually doing admin work. It's incredible how much time they are spending on that. And unfortunately, because of that, they cannot see more patients. Of course, they're saying, we need to see more patients. Yes, sure. Maybe one solution is bring more nurse practitioners or more doctors. But at the end, I think we need to focus actually on how we support our clinicians. I think it's really, really difficult for them now to do their job. I just have a meeting with them yesterday discussing about that. Imagine actually in Carlington, we have a 50% of our clinicians, they're not working, they're in sick leave because they burn out. So they cannot manage. So at one point they decide to stop for a while. So that is difficult. So I think the big problem we have is they feel they don't have support to do navigation with the clients. Our clients need so many support, not only medical support. They need more navigation. They need to understand what we offer in the community, what kind of service we have. So unfortunately, it's the doctors or the nurse practitioners who have to sit with the client and explain all of this. And sometimes they are not specialists. They don't know about that. So it's taking so much time for them. So I think what we need, and in the discussion with all of them, is actually what they need is they need support in that part for navigation, to help clients to seek for other service, other help in the community. We have many organizations do that, but actually it's all on our clinicians. So I think I don't want to take more time. I know we are in 1 hour only, but actually I think that's the big problem. Of course, I agree with everybody in the rest. All of that, we can do many changes. But I think at one point we need to stop, think about our clinicians, because they are the key for our success. So at one point, I think we need to support them, and that's what they're asking. So I think we need to find ways how to help with that.
Okay. Well, Omar, thank you so much. And sorry to put you on the spot, and we really appreciate you bringing the perspective. The one I won't forget is the notion of 50% of your clinicians being on a leave, given what we've gone through. So thoughts and prayers, your amazing team, and to those folks, please, if you wouldn't mind in your next meeting, let them know that the neighbors in our community really appreciate their work. And welcome them back when they're ready to come. We do have, for folks who are with us and joining us, we are not doing a hard end at 3. Don't worry, we have some time for discussion. That's important for us to make sure we get the advice, because a lot of folks have made the effort to be here, and we appreciate you coming. But Ed Cashman from the Ottawa Health Coalition, you've been doing a lot of advocacy around access to healthcare in the moment that we're in. I want to hand it over to you before we open it up for some discussion. Over to you.
Thank you, Joel. I'd like to put a face on this crisis. We can talk about data or statistics, but I think if you realize there are real people out there, it's important. So I want to tell you about Christine. Christine was a senior who lived in Centertown, a good friend of Joel and mine. Christine had a doctor until her doctor decided to retire. That was 5 years ago. And he kept his hand in. He moved to Italy, but somehow she was able to get her prescriptions renewed. Things were fine. She was in good health, or she believed she was. And she thought she was weathering not having a doctor. Then she got sick. And then, as you know, COVID came along. She developed an infection in her lungs and it wouldn't go away. She struggled to find somebody who could see her, and she struggled. She finally got to see somebody at the Somerset Street West Health Clinic. And they put her in an ambulance and sent her to the Ottawa Civic, where she was diagnosed with lung cancer. And while they were doing that, they discovered she had breast cancer, and within 3 weeks she was gone.
Wow.
Right? So that cancer was in her growing, but she couldn't get a diagnosis to find out what was wrong with her. So that's to let you know there are people like Christine out there, and people that we will lose, right? And I think that was a big loss for us and for the community to
Gave
lose
a lot
someone
to our
like her.
country. Absolutely. Christine gave a lot to our country.
And oddly, Christine was a fighter for other people, but when it came to her own health, she wasn't as good advocate for that.
The irony.
But when we talk about this crisis in healthcare, in primary care, I want to tell you that there is a void, right? There are people that have care and people that don't. And when there is a void, there are lots of scammers and con men that will step into that void to take advantage of people. Michelle, you referenced Apple Tree, high volume walk-in clinic, but they're for profit, right? They're trying to make money. They're trying to make money from people. I also have to tell you about Shoppers Drug Mart and Loblaws. Gail and Weston, the guy that scams you at the grocery store, is now wanting to scam you in terms of healthcare. And he's being invited to do that by our premier in this province. We've seen clinics in this city start to charge a subscription fee or a membership fee, $10,000 a year, and you can come and see me. And they're somehow getting away with it. With Joel's help and a wonderful person called Adrian Solnicki from QP, we went on a tour of private clinics back in January in the cold of the winter. And we had a really good crowd that day too. People were really surprised to learn that these clinics have moved in. This is American style medicine, and yet it's happening here in our city. We also know of a couple of pediatricians in this city who now have hired some RPNs, and he's able to somehow charge for the services of the RPNs because there's a loophole in OHIP and that was mentioned earlier. So there are scams out there, and people need to be careful of privatization, but more importantly, profitization. People are making profits from our healthcare, and that's not what we're supposed to be about, right? Our values as a country, we decided in the 60s that we wanted to offer hospital insurance and medical insurance to make sure that people saw a doctor or got the medical care they needed based on need, not on the size of their wallet. Michelle touched on it briefly, but to go back to Joel's original question, the social determinants of health. Ottawa Centre or Centre Town is not full of healthy people, right? We have a mix. What most of us love about Ottawa Centre is that it's a great diversity, but there are people that are falling through the cracks. People based on their race or their age, their gender, based on their housing status, I love your t-shirt. People who are not housed properly are not healthy, right? And the two, sadly, don't go well together. So social services, disability, all kinds of things, right? So we need to focus on making sure that everybody has access. So to that end, I'm going to put a shameless plug. The Ottawa Health Coalition is planning a vote on whether people want to see privatization come into our communities. That's on May 26th, 27th. Those of you in the room, I'll pass you a brochure at the end of the meeting. But this is one way we can send a message to our government that what's happening in terms of privatization is not right, and that we all want to go back to a single payer healthcare system in this country, in this province. Thank you.
Thank you, Ed. Thank you very much. Thank you, everybody. Okay, well, look, we've heard a lot this afternoon, and my takeaway that I keep hearing again and again and again is folks are really interested in innovative approaches to care. We've had the perspective of community health centers here. We've had the perspective of nurse practitioners here. On is here from Smooths, bringing the community perspective that you have done. I agree, a lot of survey research, a lot of expertise being brought to bear. But for people who haven't had a chance to speak yet, there any questions you wanted to ask? And Ethan, I'd ask if you're watching the Q&A function on Zoom, you can seize the, oh, there we are. Look at you. This is the digital tools. Why don't I just read out some of what we've got on Q&A to get us started, and then we can break in from there. Tara writes, will links to programs mentioned, Seniors Hub mentioned, the last presenter be shared afterwards? And there's a hello to you, Shireen, from the Art Care panel work. Tara, the answer to your question is yes. We were coming up with a report. That report will have links to documents that we hope people will read. And we do want to provide a report.
And I will make sure, Joel, that you get the whole comprehensive primary care strategy that the group of primary care providers, including Joanna, the academic family health teams, the community health centers put into Ontario Health East, which is, and just in terms of the scope and the scale of the issue is that we had costed out approximately in the neighborhood of $100 million to support the scale of 150,000 individuals without primary care access to services here in the Ottawa region or in the Ottawa area. And so I will make sure that you also get a copy of that. We submitted that and made that available. So just attach it to just in terms of the background and information.
Okay, thank you. Thank you, Michelle. So Karen, to your question, yes. Now, Carolyn, hi, Carolyn. I know you, my neighbor, writes to say, we would like to support the proposal advanced by SUS with Centertown Community Health Center for a Seniors Health Innovations Hub, employing nurse practitioners to provide geriatric primary care. The SHE will also, SHIH, the SHE will also advance the adaptation of new technology for use by pre-frail seniors, not just Carolyn, but Terry too. Hi to you both.
They're in Vienna.
Pardon me?
They're in Vienna.
They're in Vienna.
Yeah, we have Baron at our house.
Oh my goodness. I hope you both enjoy Vienna. It's a beautiful city. I saw it years ago. So Edie Gardell writes, Ontario's healthcare planning is backwards by paying for mega hospitals, Ottawa, Windsor, Niagara with public-private partnerships. We need small, effective, and much cheaper models with community hospitals and primary healthcare teams within the 15-minute city neighborhood where patient care for all ages comes first. Okay, thank you very much for that. That is Edith. Edith there. Nice to see you. Nicole writes, just a comment. What type of case manager type role within multidisciplinary teams would be so very helpful to help clients and families living with more complex social and health situations navigate the challenges associated with accessing appropriate and helpful community services? So
I think that's exactly what I was talking about, that many community health centers. So for us, we have community health workers, we have nurses who do some of that system navigation, from helping people fill out housing applications to making sure that they are getting their income tax returns filed and are getting all of their benefits that they're entitled to, you know, the gains benefit, all of those kind of benefit pieces, but also letting people know what is available in the community. And that can be really hard to find, even what those supports and resources are. And, you know, Joanna mentioned this, as did Anna, is that that's where the interdisciplinary team really comes in, and the supports for primary care providers, whether it's a nurse practitioner or a physician, to be able to spend that time in working with somebody to support them around that system navigation. And I will say, as somebody who even works in the system, when you're facing a healthcare crisis your own self, you still need somebody to help you navigate that yourself, because it is a complex and overwhelming system. And, you know, and that's probably another bigger question about how we can make our system less complicated, but, you know, yeah.
Okay, fair.
Okay, having just come back from the Social Housing and Human Rights Conference, thanks to you, Michelle, you're out getting there. I think I need to add that in this, we need to also acknowledge that deeply affordable, appropriate housing and food security and health things that tend to be overlooked in the big picture. Just one quick example, my daughter who is just here, there are 4 humans in her 1-bedroom apartment.
Oh my goodness.
And 3 of them don't have a primary care physician. One was just at the Peter Carlton recently, and he, like, 2 of them don't have loan cards because of homelessness involvement, and we're trying to work on the ID stuff and all that. And they live on my cabin, and 2 of them can't find their way to my health center, which is Centertown. to get there, I think, for their own reasons. I'm worried about them if they can't even get their own card, how do they get healthcare and trying to get them the housing and food security, those are two big pieces of healthcare problems.
So the social determinants of health.
Yeah,
Drawing the links. And we've had this
Exactly.
debate this week, just to briefly mention it and then move on. I'd really like to hear from others too. There was a letter written by our mayor, Mark Sutcliffe, to the Municipal Affairs and Housing Minister around Ottawa's allocation for the Homelessness Prevention Fund, which was much less than the city was looking for. So that advocacy, we'll note that, maybe link that to the report. I mean, if we can get folks housing, and my understanding is if we get the allocation Ottawa was hoping for between $15 to $17 million, we can get 54 units of supportable housing in the city, which would make a tremendous impact in helping people, not having folks afford a room for one bedroom apartment. No, absolutely.
Because of other issues, they're paying full rent in 415 nightcap.
Right.
But for humans and for cats, I keep saying they need to issue more.
Shireen's comment, Erica? No, not at all. Thank you. So Shireen writes, we can't consider any healthcare interventions that don't take the full person into account.
Exactly.
Yeah.
Health should not depend upon where you live. Amen to that. Anybody else? I'm not gonna put people on the spot, but just wondering if anybody had any thoughts they wanted to share here in the room?
I can just say, speaking as a worker at the Civic Hospital, non-medical worker, support services worker at the Civic Hospital, we see, I think that the primary impact of the failures of identifying people's healthcare needs before they end up in hospital.
I see.
And then we certainly see, like I see constantly working on the units where people who are already really sick and have, ended up obviously falling through the cracks, end up in the system. And then unfortunately, because of the failures of the system within the hospital, people actually continue to deteriorate while they're actually physically in the hospital. And then so they've gone from a place where they're not getting care to a place that is literally falling apart. So we are in serious crisis. Frankly, I think we need to get rid of Doug Ford. Ultimately, I think we're going to have to start talking about a general strike or some form of political action that gets rid of Doug Ford. Because I don't see how we can continue to fight for piecemeal gains when the administration of Doug Ford is lighting fires everywhere that have already been smoldering for decades. So ultimately we have to get rid of Doug Ford.
Those are not the good fires to light either.
Thank you, Dave.
Dumpster fires, it's called.
Anybody? Oh, sorry. Tara also, right? Thank you, David, by the way. What can be done to support and reduce administrative burden on primary care providers? Because the apple tree model is terrible for patients, but obviously appealing for many physicians who would rather pay apple tree 30% and see walk-ins than deal with running a practice. Also, could we, the province, require walk-ins to roster patients to a doctor or nurse practitioner and provide comprehensive primary care? Now, Shireen, if I'm not mistaken, this was a major part of the ARCA report, and Joanna, I see your hand up. So why don't I go to you first, and then maybe Shireen, if you can come in afterward, the notion of automatic rostering. Ethan, if we could unmute Joanna, or Joanna, if you're able to unmute yourself.
There. Hello. No, and I don't know. I don't know. I would love to have people rostered, and I feel like the apple trees really do often get you to sign that rostering form, but then you don't get the follow-up with it. But so I can't answer that. But what I wanted to talk about was I really wanted again to say thank you for everyone interested, and the questions have been so thoughtful. And just to reiterate, I don't know if I said it enough, but I would love everyone to think about how we can help get the message that primary care and the team-based care that we're talking about, and even what a nurse practitioner is in the world of discussions to change that dynamic. And I heard you say about, the mayor again. And so just to put that out there, that was another ask that I wanted to have, is to think about how you could contribute to helping us in our cause. And I see the messages to me about, should we be looking at how we submit a proposal? And that's the issue right now, is that there's no call for proposals, but we're just kind of trying to get the message out there that we have one on the ready to go. as do the CHCs and the FOs and the academic that's here in Ottawa. So anything that you can do if you want to feel like you're doing something, because you're right, it's the individuals that are really suffering in this process. And so we'd love to help if we can. And so write some letters and get the word out there that Ottawa is super keen to address this issue. So thank you again for having us.
With all hands on deck, right, Joe? With all hands on deck. Anna, did you want to get in, Michelle?
Yeah, I have actually, I know that there is the team approach, but we have been contacting the Restored Clinic.
Yep.
And talked about nurse practitioners, but it has to come out of the budget of a clinic like that. And I don't see, you have a physiotherapist who can charge the OHIP for their services. Why can't nurse practitioners do that?
Why can't nurse practitioners bill as physicians can bill?
If doctors can do it, why not nurse practitioners? Because we have looked at starting a nurse practitioner-led clinic. It is a major undertaking. It involves a board. It is very comprehensive. So I don't know if
could I answer that a little bit? One of the family, just so you know, if you do start a nurse practitioner-led clinic and you have a board, then you could have satellites of that clinic. So all we have to do is start with one that I feel like it could build. But you're right, it is a major undertaking. And then I think I put it in the chat, but that you've tried to ask the Ministry of Health of Ontario to consider OHIP billing for nurse practitioners, but it has so far been a very hard no, because again, 1 in 10 tax dollars for Ontario, and I feel like, Bill, you can speak to this more, is physician services. And so that they have no interest in increasing that. And what's different also about when we think about some of the proposals that are going forward is to look at, like, the CHC model is all in, it's the salaried care. And I think some of the hidden costs of healthcare are when the physician services, which I would argue from one of our speakers saying that the private healthcare, like all physicians bill in a fee for service. And so the idea that they're not for profit, I might argue, but in a salaried model that all the healthcare costs are upfront. And so just to think of that comprehensive care when you're dealing with the level of complexity is something I think should be considered first. Anyway, so just my 2 cents about that, but I agree with you. Physician or OHIP billing would be ideal, but I don't think it's something that would ever be considered in the near future.
And can I actually want to speak to really about that. And this is a bit of, I'm going to try not to get jargony, but I am going to give you a bit of like inside baseball about how healthcare is funded. So part of the OHIP billing and issue around the physician compensation and why we don't have some of the more models of the healthcare is because our physician compensation and how many different kinds of rostered alternative compensation models there are besides fee for service is negotiated every 5 years between the province and the Ontario Medical Association. The Ontario Medical Association is, it is made up of like 50% of that is largely specialist care who are all on a fee for service hospitalized model. There is only, and then even the physician teams that are non-salaried are also still OHIP modeled, except that they are funded on what's called a blended capitation models, where they get a certain amount per patient to be seen that's adjusted for age and sex. And then they bill OHIP around certain other fees and services, and they get additional incentives if they hit performance targets. So, but all of that is negotiated with the Ontario Medical Association, that is negotiated on behalf of physicians, which is negotiating for our primary care budget. So nurse practitioners are not included as part of that negotiation. Mm-hmm. And if we want to expand alternative models of primary care, the way that the agreement is structured is through the OMA, which is about physicians. And so it is also working within the physician groups. And so the CHCs, about 10 years, maybe more than 10 years ago, maybe 12 years ago, maybe even 15, became a branch of that to negotiate for their own salaries because they used to be left out of that completely, and now they're in part of that model. But that's one of the reasons how come when you ask about can we roster? Well, Apple Tree actually doesn't want us to have people rostered. They get more money in a fee for service model than having people roster, because if you roster, then you have to provide that follow-up care. You have to provide that comprehensive follow-up care. It means you have to keep the records and monitor and follow them up. If somebody comes in, you have to follow up with the diagnostics, which is a more expensive model of care than just coming in and saying, I have this one issue that you see, and then I walk away. And
I need my asthma meds.
I need my asthma.
I need this.
I need my asthma meds. I have strep throat. I have pink eye. I have whatever it is.
Right.
In terms of those issues. It's very effective then to see somebody every 7 minutes. It's not as cost effective when you have a primary care and the issues are interrelated.
Right.
And that's why other kind of the models, but it's the OMA in our current agreement and structure that has been set up. And this is variations of this across Canada and the province, but certainly in Ontario, it's the OMA that negotiates with the province how much we're spending in other than fee for service models of care, because of the way that the OHIP billing structure is tied to the OMA agreement. And it becomes very difficult for the provincial government to shift funds out of that OMA primary care pot into an alternative model, because it's all negotiated with the OMA.
Interesting.
And so when we're looking at the current investment, I see Shireen has her hand up. She probably has some more in-depth information from the report within this. So when we're looking at the investment that we've heard announced, the $230 million pots of money added up to $6 million, those were actually things that were negotiated with the OMA before that they were announced in terms of the expansion of team-based care. And the first 30 million was really only physician team-based care, not a broader interdisciplinary team-based care. So groups of physicians practicing together rather than the broader team, and now they've expanded it.
Okay, thank you, Michelle. Shireen, over to you.
Thanks so much. And I think one thing that you might find interesting from our discussions at Our Care was the idea that not every physician or healthcare provider needs to perform the exact same way to be considered doing their job. For example, at a nurse practitioner-led clinic for mental health care, we don't, they may see fewer patients as a result of their model, but they may also be providing much better care than could be provided by, say, having 4 appointments in that 1 appointment slot. One thing I think needs to be considered is that, and we have this in our recommendations, that we need panels to be with these teams, patient panels, and they need to be part of deciding what is the outcome measure that's appropriate for like higher need patients or low needs patients, for that matter. If all you need is to go in and get your asthma inhaler refilled, maybe that's going to be a different type of clinic that only gives you 5-minute appointments.
Right. So what I'm hearing, if I can identify a consensed thread here, is to meet 150,000 unattached folks in Ottawa, there's a collaborative approach is helpful, but one model is not going to be able to fill that void.
No.
Community health centers on their own is not going to be able to fill that void. Innovations with nurse practitioners not going to be able to fill that void. A presence we don't have here today, we tried, but we will do it in follow-up. Family health organizations, physicians working in that environment, not going to fill that void. It needs a much more comprehensive lens. Could include pharmacists as well. Tara writes, even if nurse practitioners can have bill hook, why can't clinics or team practices like Restore get provincial funding for the nurse practitioner's salary? Could the province allow this without the OMA?
No.
So the answer to that, Tara, is no.
No, it's completely negotiated, the number of alternative payment methods for primary care through the OMA agreement.
Okay.
What about?
And then Tara writes about rostering. So if we wanted to force walk-ins or any clinic to roster, the OMA would need to want this. It isn't something the province could legislate.
The OMA would need to want it and negotiate that would be an agreement to do that.
Is it possible to lobby the OMA?
Yes, you can absolutely lobby the OMA. The OMA, the reason how come you can't roster is because in a fee for service, you can just bill OHIP and it's built into the model. The OMA does not actually at this point, has not shown any indication that they want to surrender that right in their agreements. And so they will not agree to any legislation that limits the right to practice and set up something like walk-in clinics. Now, I will say, if I can just bring in an example from Northern Ontario. I grew up in Sault Ste. Marie.
Ah, really?
So,
I didn't know that.
Yeah, so I grew up in Sault Ste. Marie. Interesting fact about Sault Ste. Marie. We have two main industries, the used to be Algoma Steel and the pulp and paper mill. And as an employer, those two employers got together and actually initially funded and started the Group Health Center, which is a health service organization. It's an old archaic model, but it is interdisciplinary team-based care. And when I was growing up, 90% of the population of Sault Ste. Marie was rostered to a group health center. And in fact, there were no walk-in clinics. I didn't know what a walk-in clinic was until I came to university, because the group health center had integrated walk-in clinics as part of their practice. And they still today have integrated walk-in clinics as part of their group health center practice, even as they've now expanded with additional family health teams. And they have an integrated walk-in clinic in their emergency department. So when you come into the emergency department, you're actually either triaged to the walk-in clinic or you're triaged to the emergency department based on the urgency of what your need is. So there are solutions within communities, but I also find it interesting that this was a community that set up for primary care as a rural, as like a northern community, fairly isolated in many ways. It's, you know, it's 4 hours to the next big city, which is Sudbury. But they actually created this model as an access as an employer, because they knew that access to primary care, and they like it, you know, there's been challenges and it's been eroded, but that was actually part of the model. Is actually the community created the space that then there wasn't actually walk-in clinics within that community for the longest time.
Oh, wow. My goodness. Okay, well, anybody else want to get in on the last round of any questions before we end with some takeaways? Well, let me just thank everyone. Oh, Anna, over to you.
Yeah, I still have something, an idea. You know, when the kids were small, we had a public health nurse after I had the babies. And I have tried to get an answer from Ottawa Public Health. Couldn't there be a community nurse doing outreach to seniors? And I don't know, it's just, you know, they don't have the budget, you know, it's no, but no only means that you have to try harder, right? You learn that as a little kid.
I've never known you to take no for an answer.
Spoken like a true community activist.
Well, sorry, go ahead.
And it's possible in Renfrew County.
I was gonna say,
They use
paramedics.
paramedics to do check-ins on seniors, and it's a pilot project.
Yeah.
But it's world famous because people really like the idea and the concept.
Yeah, so that's.
One of the people that fought for that is our colleague, John Yakubuski, who's a member of the government, who's been advocating for that for a very long time.
Yeah.
And I met some of the paramedics in Renfrew County that do the look-ins.
Yeah, so I think, we have to try all kinds of ways, you know?
So what I'm hearing is our place to, oh, sorry, go ahead.
I was just going to say, I'm from Australia originally, and my parents are both much older. And when my dad had a small stroke, and they really want to keep people at home. And so they had auxiliary care who came and put in handholds so he could stay at home. And this was all funded. They didn't have to pay for anything. And shower chair in the shower, a commode chair, somebody would come and help shower him, and they would assess him. The Royal District Nurse came and did his dressings. It was a minimal charge, but it was really focused on keeping people in their house.
Right.
And it was constant. and his GP would come and see him at home.
Yeah.
Unheard of now.
Yes.
But it was really multidisciplinary, and I think still now they're trying to keep people at home longer.
Yeah.
But they just seem to have better healthcare. I mean, most countries seem to have better alternatives for.
Yeah.
Fair enough. And the link between community care and home care is critical.
Absolutely.
It's a critical piece. So if I could suggest we put a bookmark in this for now, I do want to thank all the folks who joined us online and here in person. As I said, our team, that is Ty, Erica, Ethan, and myself, we're going to be working on a report with links to other documents that we're going to be sharing with Ontario Health East. Karen O'Brien is here from Ontario Health East. Karen, thank you so much for joining us this afternoon.
Thanks, Joel. And I just want to let you know that my colleague, Jean Thomas, who is the director that's responsible for the primary care file at Ontario Health East, has also been listening in.
Oh, good.
Wonderful.
Hi, everyone.
Thank you.
Yeah.
Very appreciate
Hi,
it.
Jean.
Appreciate that. So we are going to be working on this report. I'm certainly feeling the pressure of the community to do this work quickly. So we aren't going to be lagging on this. We're in the community next week. The legislature's not sitting next week. So I've got some time to sit at the laptop and make sure we get something out. We want to, for those of us who took time to come and prepare some stuff, we want to show you a draft first before this goes anywhere and provide you, Karen, and Jean and others with something to take back to the ministry and to the minister. Personal thanks to Erica, to Ty, and to Ethan for making this happen. Thank you very much. And stay tuned because this is a really important discussion and I very much appreciate community expertise around this table. I hope you all get a chance to enjoy the beautiful weather that is outside tonight if you haven't already.
Awesome. Thank you for bringing us together.
Yes.
All right, and Michelle, thank you for this owl. Very
Yeah, it's like really cool, eh? It's like, yeah.
It scares that you